Very good morning to all of you who are present here physically as well as who have joined online. Today, actually, we have an eminent speaker. He is Dr. Duminda Yasarathne from the Faculty of Medicine. He is a consultant physician as well as a senior lecturer attached to the Department of Medicine. And he was a secretary of the KSM as well as at the moment he is helping immensely to us, the KSM, as a co-editor of the Sri Lanka Medical Journal. I have to commend their work. Actually, they have brought the level of the journal to a very high level. So we are very thankful to you. And I think today he will be presenting on sleep apnea, actually, which is a very sort of not a very hot sort of it's an immense problem, but it's not recognized and managed well at the moment. So I think this is an important lecture, and I invite Dr. Duminda Yasarathne to proceed with the lecture. Thank you.
Morning to all of you, and thank you very much, Dr. Article, for that kind words of introduction. And it's always a pleasure to join in any activity of KSM, and it's a privilege as well. So I'd like to again thank the organizers, Dr. Article and Dr. Nandana Jayathiraka, for inviting me and giving me this opportunity. So I'll start with a few scenarios here. A 35-year-old man who was recently diagnosed with high blood pressure investigated for a secondary cause for hypertension, but none was found, and he complains of feeling tired and sleepy during the daytime. His wife says he snores very loudly at night. So not an uncommon scenario. I'm sure most of you have come across a patient like this. Another scenario, a 60-year-old man presents to the A&E with sudden onset face, arm, leg weakness, a stroke. He was diagnosed as an ischemic, having an ischemic stroke. No comorbidities like diabetes or hypertension, with a BMI of 32. And in the hospital, it was noted that his oxygen saturation drops. And also, his nearby patients complained that he snores loudly at night. So again, a patient with a stroke. Another scenario, a newly married couple comes to the clinic. The wife complains that the husband snores. She's alarmed to see him not breathing at times. So the wife is alarmed to see the husband not breathing at times during the night. And she has moved to a separate room. And husband has a BMI of 38 and complains of falling asleep during the daytime. Again, not an uncommon scenario. So we have three case scenarios: a man with young hypertension, another gentleman with new onset stroke, and there's a couple with marital disharmony. So what do they have in common? They all have daytime somnolence, and they all demonstrated episodes of cessation of breathing, and they all had snoring. So with that, we come to the topic: obstructive sleep apnea. How we can translate the theory into practice, and what are the challenges we see in our setting. Obstructive sleep apnea is something new. It has been there for a long time, and people have been aware about obstructive sleep apnea, but still there's a lot of things to be done in this field. So I'm very happy that this topic is given a chance to be discussed in this forum, and I will be briefly touching on some very important aspects where every medical officer should be aware of. So this is the plan of topics that I'm going to discuss. So we'll start with the definition. What is obstructive sleep apnea? So the term itself says what it is. It's apnea, cessation of breathing during night or during sleep because of obstruction of the upper airway due to pharyngeal narrowing. So that's the definition. Why there is pharyngeal narrowing? There are a few causes. It can be functional, reduction in the tone of the pharyngeal muscles. That is one reason, or it could be anatomical, due to anatomical obstruction of the pharynx. And commonly, it can be combination of both functional and anatomical reasons. So that is the reason for this pharyngeal narrowing, which leads to obstructive sleep apnea. Obesity is identified as a single most important risk factor for obstructive sleep apnea syndrome. If you look at this picture, you can see in this second, your right-hand side, an obese man who has excessive fat in the submental triangle as well as in the retropharyngeal space. So there's a lot of fat deposition. So that causes the tongue to be displaced, so to upwards and backwards, and also the pharyngeal wall moves forward. So effectively causing an obstruction or a narrowing of the pharyngeal space, which is a reason for this pharyngeal or the upper airway obstruction. Not only the obesity on the fat deposition, the significant abnormalities of the orofacial region like narrow mandible, narrow maxilla, microrathia, retrognathia. So all these conditions can cause significant narrowing of the upper airway. But these comments are not that common, at least not for us medical people who see patients, but I'm sure for the dental people this is not uncommon. But more commonly, we see these patients. These are very, very common, not abnormalities, but common manifestations, like you get high and narrow hard palate, then elongated uvula, prominent tonsillar pillars, then enlarged adenoids, macroglossia. So all these things are not uncommon. There are a lot of, it's common in the population, and most of these patients can have an effective reduction of the pharyngeal space leading to obstructive sleep apnea. And not to forget these congenital disorders like Down syndrome and also other endocrine problems like hypothyroidism and acromegaly, which can cause this tongue, like macroglossia, large tongue, which can again cause the same symptoms. And also alcohol and sedatives can reduce the pharyngeal tone, and which can exacerbate the obstructive sleep apnea. So that's about the definition of obstructive sleep apnea. So we are talking about the upper airway and especially the pharyngeal region. So what about the pathophysiology? You can see here. See this cursor here. So upper airway. So when the patient falls asleep, there's a relaxation of the upper airway muscles or the pharyngeal muscles, which causes the obstruction. With the partial collapsing, you get loud snoring. But when it is completely collapsed or obstructed, the patient goes into apneic spells. So we call it apnea. So there are few terms that we use in obstructive sleep apnea. We call apnea and hypopnea. So hypopneas are like 30% reduction of the upper air flow, whereas apneas is complete cessation, or 100% obstruction of the air flow. So with that apneas and hypopneas, patient's oxygen level drops, which we call desaturation. There's more than 3% desaturation, and that in turn causes the patient to be that itself opens up a cascade of events. So the brain starts working fast, and there's a fast heart rate, and ultimately the patient wakes up. Sometimes patients fully wake up, so they are aware of what's happening. They wake up in the night and say, I can't breathe. Sometimes the patients do not wake up fully, but subconsciously they turn side to side. So with that change of posture, this obstruction relieves, and now patient starts to breathe again. So there's bit like gasping breathing, and now the oxygen level comes up. But this goes on and on like a vicious cycle. So again, after a few minutes, patient again gets the obstruction, and again the same scenario happens. So that is the pathophysiology of obstructive sleep apnea, and that happens during the throughout the night. Sometimes, so we measure the index, what's called apnea hypopnea index. Some people have more than 60. So 60 is that every minute there's a more than 10-second apneic spell. So you can imagine if there's more than 60, so every minute patient goes into apneic spell. So in actually speaking, that patient is better off not sleeping than sleeping, because that sleep is like a torture to that patient, to the whole body of that patient. So it is that severe. It can be that severe. Okay. So with this hypoxic spells, what happened? There's a lot of events happening inside the body. So one of the important thing is development of the pulmonary hypertension. So you can see the second picture here. You can see these purple arrows that indicates the pulmonary arteries are narrowed, or the pulmonary arterioles. Or the capillaries. There's a vasoconstriction of the pulmonary arterial system. So if you look at the like systemic blood flow, if there's a hypoxia to the muscle, what happens is there's a muscle blood vessel relax, because that they need more blood. So more blood is diverted to the muscles, so there's more oxygenation. But the autoregulation in the lungs is different. If there's a area where there's a hypoxia, that the vessels that supply, or the arteries that supply to the hypoxic area gets constricted, because otherwise there will be a lot of shunting, because there will be a lot of deoxygenated blood getting into the systemic system. So, but that is a protective mechanism. If there's a localized hypoxia, like for a pulmonary embolism or a foreign body, whatever, there's a localized hypoxia. But if it is a global hypoxia to the lungs, like in obstructive sleep apnea, then there's global vasoconstriction of the pulmonary system, pulmonary arterial system, which in turn leads to pulmonary arterial hypertension, which can be treated in the early stages, but once it's established, it's a very difficult condition to treat. And patients, after that, it will be a like progression of the events. Patient develops copulmonale, there's edema, and it's very difficult to treat. So that's one of the main dreaded complications of obstructive sleep apnea. And also with obstructive sleep apnea, there's sleep fragmentation, increased inflammation, endocrine changes, there's less energy expenditure, increased obesity, and also patients develop insulin resistance and beta cell dysfunction. So all these cascade of events can lead into hyperglycemia, type 2 diabetes, so patients, and also obesity. So all these metabolic risk factors get worsened with obstructive sleep apnea. Not only that, there's inflammation and endothelial dysfunction in obstructive sleep apnea, and oxidative stress. So there's a lot of chemokines, cytokines involved. You can see the next slide, which again lead into endothelial dysfunction and cardiovascular problems and coronary vascular diseases. So all these cytokines are involved in obstructive sleep apnea, which I'm not going to go into detail. So this is not an isolated disease, or this is not a respiratory illness. This is a systemic illness. There's a lot of systemic manifestations of obstructive sleep apnea, and the patients also present with multisystemic complications. So it's very important that all doctors treating patients, can be medical, it can be like any stream that you are treating patients. It's important to have an idea about the main symptoms and the main, at least the basic understanding about obstructive sleep apnea, because that is so common in today's practice. Okay, so what are the main symptoms the patients come with? The main features that patients present with would be snoring or daytime somnolence. So most patients come with daytime somnolence because that is what they are aware of. So they fall asleep. They might be at a lecture, or like they might be at a meeting, or they might be traveling in a vehicle, so they fall asleep. So that's very common. So patients come with these symptoms, and not only that, it can associate with headaches and lack of memory or concentrating ability. So all these things can coexist. And also the spouse would complain that you snore at the night. So patients also come with snoring, and sometimes the spouse also say that the patient stops breathing at night. There are witnessed apneic spells, so that might also be a reason for the patient to present. So these are the commonest presentation when the patients are aware of the disease, but most commonly they come unaware of the condition that they are having. So it is an incidental finding in uncontrolled diabetes, high blood pressure, uncontrolled blood pressure, new onset stroke without any conventional risk factors, then ischemic heart disease, especially heart attacks at night. So I'm sure that all of you have heard about these heart attacks that occur in the night, and also strokes at night, because now earlier we discussed that hypoxic spells. The patient is hypoxic, and also the patient is having high brain function. The brain is trying to open this up, and the heart rate is increased, and that's the ideal time for the patient to get a heart attack. And also these patients are polycythemic, so they are in a hypercoagulable state. So with all these factors, they are very good candidates to get these heart attacks and strokes at night. Also arrhythmias and polycythemia. So we get a lot of referrals from the hematology colleagues with patients with polycythemia. So you exclude the normal causes like smoking and dehydration, and if it's persisting, you have to think about this obstructive sleep apnea as a cause for polycythemia. And again, it's not uncommon for these patients to present to psychiatric clinics. They can be having personality changes and reduced memory, especially with this daytime somnolence, morning headaches. They have a lot of psychosomatic manifestations, so they go for psychiatrists, and sometimes we get referrals from them asking us to look for these problems, and it's not uncommon as well. Okay, so we have discussed about the definitions and the basic pathophysiology and the symptoms of obstructive sleep apnea. So what are the challenges we are having, especially treating and or diagnosing these patients or identifying patients in our scenario or our clinical settings or in this culture? So snoring, it is traditionally accepted in our society. We say a patient is not only in English literature, they say patient is sound asleep. I don't know how that has come. A sound asleep. You should be silent asleep, no? We say sound asleep. Maybe the patient is snoring. I don't know how that has come. In our singular culture also, we say goro goro nida ganno. So we think that's a good, the patient is having a good sleep, goro goro nida ganno. But to say it's not. So it's traditionally accepted, snoring in our culture. So that's one barrier why patients do not present to you. And also, if you look at our diet, we have a good rice-based, it's a good mixed diet, but sometimes most of our people might be on a high carbohydrate, less protein diet. So there is obesity. You can see the last slide. Central obesity is not uncommon among our population. And the level of exercises. So we have, as a society, we have transformed from an agricultural based economy to a semi-industrial and a service-oriented economy. So our exercise levels come down, but our diet has not. So that's again another challenge that we are facing with. And also, we don't have that exercise culture. You go to the West, you see people running around every day, but here it's changing, and hopefully it will change in the near future. But still, there's a lot of things to be done in that area as well. These are few challenges that we see in our society. Why patients do not present early enough, and why they wait till all the complications occur to come to you. So it's very important that we make the patients and the society aware about this important condition, so they can so patients can present early and they can identify themselves and their spouses early. So what are the consequences of obstructive sleep apnea? So patients are mainly worried about the daytime somnolence and effects of daytime somnolence, because they get nodding off during daytime. There's excessive daytime sleepiness, and also their productivity is poor, and also they get involved in road traffic accidents. So drivers, it's very important. So there have been some studies. Even Professor Samad Darbatna has done a lot of studies on road traffic accidents, and one of his papers say sleep apnea is a very common reason for road traffic accidents in our setting as well. It's globally seen. And we are, as medical professionals, we are also worried about this metabolic risk, increased metabolic risk, like coronary vascular diseases, high blood pressure, diabetic, and strokes. So the patient might not be aware of that, but it's our job to educate the patient and make sure that they adhere with the management protocol today. If you look at the 10-year mortality after the diagnosis of sleep apnea, you can see here, this red one is the AHI, or the apnea hypopnea index. That is the number of apneic spells per hour. So if it is more than 30, so that is like, it's an average thing. So if you take the total sleep duration for 1 hour, there's more than 30 apneic spells. So every 2 minutes there's an apneic spell. So this is less than 5. So we'll be discussing about this criteria later on. So this is less than 5, 5 to 15, 50 to 30, and more than 30. So that is how the classification goes. So if you look at these different categories of patients, you can see the 10-year mortality. It's very proportionate to the level of sleep apnea. The higher the sleep apnea or the HI, the apnea hypopnea index, the lower the the higher the mortality as well. You can see here in this graph. So the number one reason for death among sleep apnea patients is ischemic heart diseases, and there have been studies where they have checked the coronary arteries by CT coronary angiograms among sleep apnea patients, and this shows with high apnea hypopnea index and low apnea index. So what is the level of atherosclerosis in the coronary arteries? Now here you can see there are some atherosclerotic plaques here, and the higher the AHI, the higher the atherosclerotic plaques and higher the risk for coronary vascular diseases. So that is well established. The study from Europe and also from US, it has shown the cardiovascular diseases among obstructive sleep apnea. Ischemic heart disease is very common. These are hazard ratios, ischemic heart disease and high blood pressure, and also strokes. They have a hazard ratio of around 3 or more than 3, whereas heart failure also approached around 2. So all these cardiovascular conditions are more prevalent among sleep apneic patients. The same with the strokes as well, which I'll not going to go into detail. So the strokes are also more common in patients with obstructive sleep apnea, and more importantly, diabetes. You can see here, it's very well coordinated with the level of sleep apnea. The higher the severe the obstructive sleep apnea, the odds ratio of developing diabetes, the odds of developing diabetes is higher. If it is severe OSA, that is more than 30 apnea hypopnea index, there's an odds of 2 when compared with the normal population. And even mild obstructive sleep apnea, that is the apnea hypopnea index between 5 and 15, again that can cause a diabetic. The odds ratio is around 1.5. So there's again a high incidence of diabetes among these patients as well. So we are a country with high prevalence of non-communicable diseases, and this is an increasingly recognized problem in this country. And there's a lot of activities going on to reduce the incidence of non-communicable diseases. So with obstructive sleep apnea being prevalent, we also get this is again a vicious cycle. So the metabolic complications can lead to obstructive sleep apnea, whereas obstructive sleep apnea can increase the risk of diabetes, high blood pressure, and other non-communicable diseases. So that's again another challenge we see in our system. And also lack of proper GB system is also identified as, because most patients with non-communicable diseases, they might not get properly followed up, properly treated. So because of lack of this proper GB system. So we are proud of having a good primary healthcare system, but still there are a lot of room to improve. Right. We'll now go into to the section on how to diagnose obstructive sleep apnea. So the most important thing would be to identify or to suspect patients with obstructive sleep apnea, especially when you are doing clinics, can be hospital-based clinics or your private clinics. Patients will not come with the typical symptoms most of the time. So you have to suspect. They will come with a lot of vague symptoms, headache, sleepiness, personality problems, then marital disharmony. So a lot of other non-specific manifestations where you have to have a high degree of suspicion. Once you suspect, the rest of thing is not that difficult. So basically, what we do for suspicion, there are tools that we can use. One is called Epworth Sleepiness Scale, that here you can see. So we can do a comprehensive sleep assessment. There are different scoring systems, clinical tools, and also we need to do basic tests involving thyroid functions and some other like full blood count to look at the hemoglobin level. Then sometimes patients need to do the echocardiogram to make sure that there's no other reason for hypoxia. And also to confirm the diagnosis, we will go for a sleep study. And for selected patients, we will go for imaging of the upper airway as well. Sorry, this slide, I'm not sure whether it's too visible from there. This is a picture of Epworth Sleepiness Scale. This is a very simple 8-question tool. Even the patients themselves can score their what is checked there here is excessive daytime sleepiness. So if they score more than 12, or say there's the cutoff is 10, 10 to 12 is mild, more than 12 to 15 it is moderate, and then it is severe. So out of 24 marks, so we can give 3 marks maximum for each question. So the questions are very simple. Whether you become increasingly sleepy when you are sitting and reading or watching TV, sitting inactively in a public place, or as a passenger in a car, or whether you are lying down for rest after lunch, or sitting and talking to someone, then sitting quietly without alcohol, or when you are driving. So likewise, they are very simple questions, but it has shown to be well correlated with uh, the presence of obstructive sleep apnea. But again, we have to keep in mind that all patients with obstructive sleep apnea will not score highly on Epworth sleepiness scale. Sometimes some patients do not. So it's not absolute, but it is a there's a good correlation. So out of 24, we can give a mark for these things, and then these patients themselves can score. Then there's another one called stop band questionnaire, where there's some assessment parameters also involved. So stop band is basically for snoring, tiredness, observed apneic, observed witnessed apneic spells in the night, blood pressure, body mass index, age more than 50, neck size for males. We take it as 16 generally in our system, and gender, again, male at high risk. So we look at these criteria or these parameters, and again, we can give a mark. And so these are like pre-test probability. We can assess the patient's pre-test probability using these clinical questionnaires or tools. So once there's a patient, we can always use these questionnaires. Once then if you suspect sleep apnea, then we have to do what's called a polysomnography or a sleep study. So there are different levels of sleep studies. This type 1 is the fully most elaborative or most comprehensive sleep study, which is the full polysomnography. It involves all these leads. It's EEG, electrooculogram, that is the eye movements, because there's a we have to assess the REM sleep and the sleep staging. EEG is important in sleep staging. There are different sleep stages, that REM sleep, non-REM sleep, and then patients getting obstruction in different places, because there are a lot of other conditions. Not quite a lot, but there are some other conditions like narcolepsy and then cataplexy. There are other neurological conditions also which can mimic sleep apnea. So for that, you might need a full polysomnography. But for routine use, you might not need all these things, because these polysomnography machines are not available freely. I'm sure they are available in Candy with medical research unit. There's one machine, and also in other main respiratory centers you have machines. But also we have other level 2 and level 3 sleep devices, which can be even portable. So we can use all these devices. Then the main leads are like they check for airflow, so nasal airflow, then the oxygen saturation and pulse rate, and the thoracic and the abdominal movement. So these are the main parameters. So this is, you can see the first one is total polysomnography with a lot of wires attached. Here the second one is a level 2, and third one is level 3. So the number of channels are getting little. So we can see here, this is a full polysomnography results, which is very comprehensive, which has all the parameters. But here, the main parameters you can see is the airflow. So this is, you can see the exhalation and inhalation in the first 2 arrows, the normal airflow. A patient is breathing normally with the synchronous thoracic and abdominal efforts. You can see the second and third, they have a very synchronous efforts. But after this red line, you can see that airflow is reduced. There's a total cessation of the airflow. There's a flat line here. You can see the cursor here. Now it's a flat line here up to this way, but it's still the thoracic movements are there. So now the thoracic movements are actually increasing. Now it is obstructed at the upper airway. So the patient is trying to breathe. So the thoracic movements are there. But if you look at the abdominal breathing, there's a thoraco-abdominal dysynchrony. The movements do not. Now here the movements are very synchronous, but here it's dyschronous, what we call is a paradoxical movements. So that gradually increases to a level. So this, to qualify as an apnea, there should be more than 10-second airflow cessation. And at the end of this time, patient start to take a very deep breath, like a gasping breath, and then patients again slowly come back to his normal breathing pattern, and the paradox ends there. So with that, there's a, if you look at this bottom line here, it's the oxygen saturation. So there's a more than 3% of desaturation, more than saturation drop from the patient's weight baseline. So that is a very important. So that's called desaturation. With desaturation only, the patient's heart rate goes up. There are arousals as well. Right. So this is how an apneic spell is identified in the report. This is more or less similar, but here the difference is the airflow is not, it's not a totally flat line like the previous. It is there's a reduction. There's a 30% reduction of the airflow, which is called an hypopneic spells, hypopnea. So that's a two basic difference between the apneas and hypopneas. But both can cause a desaturation of a saturation drop more than 3% from the baseline, and both last for more than 10 seconds. So we have to score manually. So the same thing here, apneas and hypopneas. So minimum 10 seconds, apnea is a complete cessation, whereas a hypopnea is a 30% or more reduction. So we need to do a manual scoring. The machines would also generate a report, but it's like an ECG report that's coming out from an ECG machine. You cannot fully rely on that. It will tell you the basic things and the numbers, but then to get the proper picture, you have to go through the full sleep report and see what, because even though it says 10, HI is 10, that is only mild sleep apnea, but that is the average one. But that sleep apneas might not occur throughout the sleep. It might be considered within about 2 to 3 hours of that patient's sleep duration. So if you look carefully at that particular segment, that segment might have a HI of more than 40. So that's possible. So because still the patient is at a higher risk of developing the complications, all the complications that we mentioned during that period of time. So that the final generalized report of 10 might not give you the good picture. So you have to go through the report and identify have the total picture for the patient's sleep report. So based on the apnea hypopnea index, you categorize if the AHI is less than 5, that is normal, then 5 to 15 mild, 15 to 30 moderate, and more than 30 is severe. So mild, moderate, severe sleep apneas. What are the challenges again? So lack of suspicion is one of the major challenges. So we have to train ourselves, and we have to educate the population to identify these symptoms of sleep apnea. This is very important, and there are a lot of programs going on as well. And then the availability of testing facilities. It's available. It's in main respiratory centers and some ENT centers as well. Till the referral system is not that established, and there are things to improve in the testing facilities as well. And the human resources, again, like we don't have specialized technicians, so that part also need to be addressed from a from a ministry point of view. So there are a few things that we can improve on that aspect as well. Okay, so once we diagnose a patient with sleep apnea, what we are going to do? Lifestyle modification in all patients is very important. So healthy diet, low carbohydrates, and more vegetables is important, and active lifestyle. So very good to see a lot of doctors in the grounds. When you go in the evenings, there are people exercising. We go to the campus grounds. It's very encouraging. Dr. Nandan is there most of the days, you can see. So it's very good that people keep themselves active and people exercise. So these are very important. The behavior modification is very important. It's indicated for all patients who have obstructive sleep apnea and some modifiable risk factors. So people who are overweight, so the patient's BMI is checked and the BMI should be corrected to the normal range, and obesity should be controlled. And then sleep position is very important. Sometimes patients without obesity, just because of the sleep position, they can get obstructive sleep apnea. The people who have a supine posture during sleeping, the tongue can fall back and then obstruct the pharynx. So they just have to have to adopt a new position of sleeping, like a lateral recumbent lateral position, and also they can support with some pillows and other conventional thing, and that itself sometimes even cures the sleep apnea. So it's very important you look at these things. So in the polysomnography, actually they have the cameras, these night vision cameras. So when we look at the the apneic spells, we can look at the patient also and the patient posture also, and that helps to correct these things. And sometimes medications like benzodiazepines can worsen or can cause sleep apnea, so that also we need to be addressed. So some patients are on a lot of sedatives and regular sedatives, which has to be addressed. Then weight loss and exercise. Yeah, so it's recommended to all patients who are overweight or obese, and there will be a lot of enough evidence to suggest that weight loss improves sleep apnea significantly. That's one of the main modifiable risk factors that we can address. So sleep position we have mentioned. So non-supine lateral recumbent position is important. Right. Alcohol. Alcohol can cause relaxation of the pharyngeal muscles during sleep. So some patients have a habit of taking a glass of wine or whiskey during night. So that also, so your history is very important. You have to get a proper history when you are dealing with the sleep apneic patient. And also alcohol can promote weight gain. So you have to advise the patients. First, about the other medications like benzodiazepines, diazepam, alprazolam, especially a lot of patients who are taking small doses of alprazolam, which can lead to these pharyngeal collapses. And sometimes antidepressants can also cause the same problem. Also, when you are treating these patients, it's just, again, it's not a single entity. Sleep apnea, if you really go into the patient's detail, then at a particular level, you have to look at the patient's phenotypes and the pathophysiological types, so the clinical and pathophysiological phenotypes. So there are obese patients who have sleep apnea, then there are non-obese patients who are having excessive daytime somnolence, then there are patients who are mainly having insomnia as their main symptoms rather than snoring or anything. That's a different category. Then there are patients with pharyngeal anatomical problems, and there are other patients with coma. There's a vast array of patients with different, phenotypic classic manifestations, which you might have to consider when you try to develop an individualized treatment regimen for these patients. So the mainstay of treatment or the principal treatment modality is the Cpap, or the continuous positive airway pressure, which just gives a positive pressure to the pharynx and which keeps the pharynx open. So because that now the problem is the pharyngeal collapse. With the positive pressure, you can keep the pharynx open, and that helps to reverse everything. So with that, the patients will be fully normal. So if you start treatment early enough, that can fully reverse your condition. But of course, if you wait if the patient waits to present till the pulmonary hypertension starts and there are other consequences occur, then of course it might be too late, but still you can control the disease. So Cpap machines, like patients can sleep with these machines. I'm sure that you all have seen all these machines. So that would immediately resolve the problems of snoring, and patient would wake up refreshed, and all the other conditions like daytime somnolence, the headaches, the concentration problems, everything will improve. There are a few problems associated with these machines also, like dry mouth, problems with the mask fit and the patient comforts. Sometimes the patients are claustrophobic and they do not want to, they are very reluctant to put these machines on. So the compliance becomes an issue. But for most of the patients, this is a very rewarding, and they say it has changed their life. Especially the patients who are having mild to moderate to severe sleep apnea, they would improve. So that is, Cpap therapy is the mainstay of OSA, and it gives a positive pharyngeal transmural pressure. So the intraluminal pressure exceeds the surrounding pressure, so the airways are kept open, and that reverses all the pathophysiological aspects that we have mentioned. So when you are talking about this NIV or non-invasive ventilation, the Cpap is one mode, but you have BiPAP and also AutoPAP modes. But basically for sleep apnea, what is recommended is a continuous airway pressure. That is the most studied, and that's the most simplest because other BiPAP and things, it might be difficult for the patient to adjust, because now patient should be confident and should be empowered to use this machine by the patient, him or herself, because these are like self-use devices. But CPAP is very easy. Even the manual CPAP, they just have to adjust a single pressure, so we can make it 10. That's it. So the patients can easily do that. But this autopap is also not difficult, but it's expensive. Bilevel pressures are we generally don't use for sleep apnea unless the patient is having other features like obesity associated hypoventilation or significant hypoxemia, nocturnal hypoxemia. The problems, as we discussed, are the patient preference. Sometimes the patients are reluctant. The cost is a huge issue. It costs more than 200,000 generally. And the insurance companies, as set, they do not cover. So there's a lot of work to be done. As a college, our College of Pulmonologists, we are also discussing these issues, whether we can get the insurance companies to, cover at least partially these costs. So we need to keep pressing these issues. And we need to develop special clinics, special sleep clinics with multi MDT or multi different teams involved. Like we need physiotherapists, we need counselors, might need a psychological counselors, we need respiratory physicians, and sometimes we need ENT specialists also for selected patients. Then what are the alternatives to CPAP? We are, one Jasin was here. He's also very much involved in these mandibular advancement devices. Some patients with mild sleep apnea with pharyngeal narrowing and tongue falling back, they improve with these mandibular advancement devices. But again, there are problems. Sometimes it's not very, sometimes it's cumbersome for some patients, not very patient friendly, but it's quite cheap. Then surgery, it's indicated for patients with poor compliance to CPAP, and also some patients refuse CPAP, and also for patients who have specific anatomical abnormalities like the things that we discussed earlier. So there are different complex surgeries which might be helpful to select if the patient is properly selected. Then bariatric surgery again is important for patients who are having morbid obesity, and that has been shown to be of benefit. Like this is the results here down are from a Sri Lankan study done by Dr. Chandimani Udugurage at Jayawardhanapura. So they are doing some bariatric surgeries and following up these patients, and which had shown a significant benefit for patients with the BMI more than 40, so morbid obesity patients. Then the pharmacological wise, there are not much of treatment that can be given for sleep apnea. Desipramine has been shown to have some effects, but it's not established yet. But there are a lot of side effects. Then for some patients with insomnia, as their major problem, the hypnotics can be prescribed or advocated. And also patients with hypoxemia, sometimes we tend to give supplementary oxygen in addition to the CPAP devices. Nitrosamide has been also tried in selected patients, again, which is under not fully established. So these are trial medications that has been tried. So with that, I think we have come to the end of my presentation. So obstructive sleep apnea is a very common condition, which is commonly and mostly underdiagnosed. Patients do not present with typical symptoms, and the doctors at all levels, from the general practitioners, the house officers, and for senior doctors, or everyone has to be aware about the main symptoms and also the patient's different presentation. There are a cascade of presentations. Some are related, some do not look like directly related, but then they can be related to obstructive sleep apnea. So it's important we screen, we diagnose, and we treat these patients. Thank you. If there are any questions, try to answer. There is also here, so we can answer. Fatigue, yes. Yes, headache is a very common. Yeah. Yeah, if you can practice that word score, yeah, yeah, like you print out in the board settings, then you can, yeah. Mm. Yeah. Not like we don't have. It's not in the lecture topics, but we are. Yeah. So yes. Very- Yes. Yes. Everything else. It's a lot of yes. Hmm. So, once again, thank you for the organizers for the opportunity.
Thank you very much, Dr. Duminda, for that wonderful lecture. It's really a hidden trait for all of us. And thank you very much, sir, for contributing to the discussion. Because sometimes in my experience, a lot of patients, as I said, the headache and some of the patients which can't explain the clinical picture, but they're a bit obese, so we need to get the investigation for that. Thank you very much once again, Dr. Duminda. I cordially invite Dr. Shanta Mehta, consultant respiratory physician, to give away the certificate and the proper appreciation. Thank you very much, sir. Thank you very much, Dr. Minda. So you are all the participants from the physical and online participants. Thank you very much for your encouragement. Yet another announcement. Candy Society of KSM annual session will follow on March 25th, 24th, 25th, and 26th. So please contribute yourself, and also the research papers. You can publish your research papers and abstract articles. The refreshment will be provided, and thank you very much.